This test involves manual palpation of the extra-articular long head of the biceps tendon within the bicipital tunnel with the arm in a neutral position. The examiner may passively internally and externally rotate the upper arm to assist with this palpation. A positive test is indicated by pain at the bicipital tunnel. This test is performed with the elbow flexed to 90 degrees and the shoulder abducted to 90 degrees with maximal external rotation to mimic the late cocking position. The examiner stands behind the patient on the side being tested and applies isometric resistance to the arm as the patient steps forward with the contralateral leg, moving into the early acceleration throwing phase. A positive test is indicated by pain inside the shoulder and is most specific for pathology within the junctional zone of the biceps labrum complex. This test is performed with the patient standing square facing the examiner with the arm forward flexed 90 degrees and with the elbow in full extension. The arm is fully internally rotated with the thumb pointing inferiorly and then adducted towards the midline 10 to 15 degrees. The examiner applies a uniform downward force to the patient's arm as they resist and attempt to maintain 90 degrees of forward flexion. This maneuver is then repeated with the shoulder externally rotated and the forearm supinated with the palm facing upward. A positive active compression test occurs when the patient reports pain inside the shoulder when their thumb is pointing inferiorly and resolution of the pain when the maneuver is repeated with the palm facing upward. A major pitfall of this exam maneuver occurs when the contralateral side is not controlled. Patients may rotate their body away from the examiner, which recruits the patient's rotator cuff and limits the test specificity for the biceps labrum complex. To control the contralateral side, the active compression test can be performed bilaterally, known as the Dines modification. Alternatively, the active compression test can be performed with the Taylor modification by controlling the contralateral wrist to prevent the patient from rotating away from the examiner. Speeds test is performed with the patient standing upright with their shoulder in 60 to 90 degrees of forward flexion, with their forearm fully supinated and the elbows near full extension. The examiner applies a downward force to the patient's forearm as they resist. This test is often performed bilaterally. A positive test is indicated by pain in the anterior shoulder or within the shoulder joint. Jurgensen's test is performed with the patient standing upright with their arm at their side and the elbow flexed 90 degrees. With the forearm in full supination, the patient is directed to pronate their forearm against the examiner's resistance. The forearm should then be placed in full pronation, then supinated against the examiner's resistance. A positive test is indicated by reproduction of symptoms or pain in the bicipital tunnel. The empty can test is a test of the rotator cuff that is performed with the patient standing upright and the arm forward flexed to 90 degrees in the plane of the scapula and internally rotated with the thumb pointing downwards. The examiner applies a downward force as the patient resists. The full can test is performed in the same position as the empty can test, but with the patient's thumbs pointing upward. A positive test indicated by pain or weakness in the shoulder implies pathology to the leading edge of the supraspinatus, the long head of the biceps tendon, and upper border of the subscapularis.